All right, so this is going to be your lecture for neuro medications, part 1. The first section that we're going to cover is from chapter 7 for anxiety, trauma, and stress medications. In Ms. Roberts' class, you have already started talking about stress and levels of anxiety. So these are those types of medications that may be used in those types of clients to help them with those problems. So the first class we're going to go over is benzodiazepines. So examples of these are going to include diazepam, lorazepam, clonazepam. They usually end in that zapam. These are going to be used for rapid relief of anxiety, but typically used for a short term because they are rapid relief of anxiety, and that rapid relief, if we're going to have to, like migraines, if we're going to have to immediately stop a migraine, we're immediately stopping the anxiety. So typically these are used in a short term. If they are used as a long term, this usually can be a great indicator that they suffer from severe anxiety, and they could have a prescription in that case for a scheduled instead of an as needed. So while taking these medications, we need to watch for several things. CNS depression, so central nervous system depressing. So we have sedation, lightheadedness, ataxia, and decreased level of consciousness. So if we encourage them to take it in the nighttime in order to reduce these effects, these are less likely to cause an issue, whereas if they took it during the daytime and they're trying to drive around lightheaded, it can cause some other problems. Also avoiding alcohol, antihistamines, and other CNS depressants, as this can increase that problem. Next we have interrograde amnesia. So this is difficulty remembering events during that medicated period. So just like amnesia, we forget what is going on, but it's only afterwards, so anterograde, so after the medication has been metabolized and out of their system, now they won't remember what happened during that time period. They'll remember from minute to minute under the influence, but once they're no longer under the influence, they have forgotten. So while they're under the influence, encourage them to, to not go buy a house or a car, avoid life-altering decisions because they may not remember that afterwards. Toxicity. So oral and IV toxicity have different symptoms, and we'll see this for a couple of different medications. So pay attention here. So IV toxicity is going to look different than oral toxicity. So if the client is taking this medication in oral form, then they could get drowsy, lethargic, or confused. Whereas IV, they're more likely to exhibit respiratory depression, severe hypotension, and even arrest. So it's a little more severe on the IV side. And then we have paradoxical response. So paradoxical, unknown, or unexpected. So what we're trying to cause is the sedation, the relief of anxiety, the calming state, right? Well, the paradoxical response is always going to be the opposite of what we're intending. So you'll see paradoxical response several times, but that does not mean the symptoms are the same. It's paradoxical in the sense of the intent. So we're giving it for a reason, but then they actually have the opposite response. So they get excited. They're not able to sleep, insomnia. They get euphoric, anxiety, rage, anger. We wanted to give them this medication for the opposite reasons, to cause these things to not become present. And instead, their response to it are these. So if these happen, of course, don't give them any more, especially if this is IV and we're in an operation or something. We're using this as our calming agent. If they're having this paradoxical response, don't give them any more because they're going to continue having their paradoxical response. So, and then let the doctor know so they can change this medication. And then lastly, we have withdrawal. So anxiety, insomnia, diaphoresis, sweating, tremors, lightheadedness, delirium, high blood pressure, twitching, and seizures. So this is the somewhat common for any type of withdrawal. There's nothing really unique here. Withdrawal, normal symptoms. So again, just like with other medications that can are likely to cause abuse or lead to abuse, I should say, monitoring for that dependency during therapy. And if they are having to stop or come off of it, make sure that we're tapering off slowly. With a lot of these neuro medications, make sure that we're avoiding taking it with grapefruit juice. And then benzos, especially with a high-fat meal. Make sure that they take it with a snack or a small meal instead. And then if we are exhibiting, CNS depression or that toxicity or severe paradoxical response that the doctor just does not want to wait for it to get out of their system, we can reverse this with flumazenil. So your reversal, your antidote, whatever term you would like to use, just make sure you know flumazenil for benzodiazepine, the Z and the Z's.
So on to non-barbiturate anxiolytics. So the example here is going to be buspirone. This is the generic form of Wellbutrin. These don't really have a very known action, but we do know that it does act somehow on the serotonin and dopamine receptors, and therefore this is usually used for the treatment of anxiety, but comes without the sedation effects and therefore the risks of abuse as the barbiturates or the benzodiazepines come with. These are also used usually for short term, but can be used up to a year, still using, getting the effects from before tolerance is usually achieved. These can be a little less major complications, just like in the beginning where it says, without sedation effects. So the little bit that's going to really be going on is more self-limiting effects, so headache, nausea, dizziness, headache, or agitation. To decrease that nausea, they can take it with food. And until they know how this is going to affect them in their daily lives, start taking it at a time where they are not required to have alertness. So being mindful of like driving activities and things. Other, mild complications are going to be constipation, so increasing their fiber and fluid intake, as this may be a side effect. And then suicidal ideations. These are going to be your key questions and answers you're going to focus your assessment on from these clients that are on buspirone, looking for any suicidal ideations. SIs is a short term for it, and if they are exhibiting any, to make sure that they contact the physician immediately. Next, we have selective serotonin reuptake inhibitors, also known as SSRIs. So our examples are going to be paroxetine, sertraline, escitalopram, and fluoxetine. These allow more serotonin to the neuron function without blocking uptake of dopamine or norepinephrine, and has a longer half-life. So this can take some time before it gets its desired effects, up to about 4 weeks. They have early effects and later effects that they might exhibit. Not everyone exhibits, but those who are sensitive to it. In the early stages of taking this medication, they could have nausea, fatigue, diaphoresis, tremors, drowsiness, and weight loss. But usually these will subside on their own. And then later, they could develop insomnia, headache, sexual dysfunction, and weight gain. So we went from weight loss to weight gain here. This can we can reduce their dose or have medication holidays like on weekends or something, or consider changing their medications if this does persist. Also, we can take it in the morning to prevent any sleep disturbances if they are having insomnia. GI bleeding can occur also with these clients, especially in combination with antiplatelet and anticoagulants, so watching for those signs and symptoms. Bruxism, which is teeth grinding, can happen. Withdrawal syndrome, it can also happen. So when we are needing to stop taking this medication or swap to a new one, we need to make sure that we're tapering off slowly and not stopping it suddenly. And then we have serotonin syndrome, because we are acting directly on the serotonin neuron junctions. We need to make sure that they have sufficient education that they need to take this about the same time every day. So it keeps that serotonin levels pretty regular. But also if the dose is maybe too high for their body to pretty much tolerate, then they can also develop serotonin syndrome. So this is going to be seen as like agitation, nausea, vomiting, diarrhea, abdominal pain, seizures, tachycardia, coma, apnea, and even death. This is going to even be more likely if they are also on St. John's wort, MAOIs, and tricyclic antidepressants, which we'll go over those two types of medicines in the next few modules too. So here's a picture of the acronym SHIVERS. So the SHIVERS are looking for those vital signs and assessment key things that looking for that serotonin syndrome that may be starting to develop. So be mindful of that acronym there. And then hyponatremia, postural hypotension, and suicidal ideations can also happen with SSRIs, but they're not as common. Usually it's the serotonin syndrome, the bruxism, and then learning about the early and later effects, which are going to resolve and which will need to be changed from. The next section is going to be from chapter 15. These are the miscellaneous central nervous system medications. So first are the neuromuscular blockers that are non-depolarizing. So our examples are rocuronium and vecuronium. This mimics acetylcholine, causing muscle paralysis, and inhibits the muscle's contraction without loss of consciousness or decreased pain sensation. So think about that. It paralyzes them, but they are fully awake and can feel everything. Because this does not cross the blood-brain barrier to stop respirations, we use this for like endotracheal intubation, mechanical ventilation, or a cessation of seizures. Now, if we're doing this for like the intubation or mechanical ventilation, we of course don't want them to remember this, and it could be quite traumatic for them. So usually, almost always, you're gonna give one of these medications with an anxiolytic or a sedation medication. So never give this by itself, otherwise it can be very traumatizing. As it's inhibiting contractions, your lungs require contractions. So respiratory arrest can also occur as a result of this medication. And hyperkalemia. This is going to be with SUCs. Actually, I think that's the polarizing on the next slide. And then malignant hypothermia. So malignant hypothermia is a sort of syndrome that can occur in clients after they have received some sort of sedative medication and or neuromuscular blocker medication, and they have an odd allergy to it. And what happens is, from what's on this picture, so they can spike a very high fever very suddenly. They'll have dark urine because their kidneys are starting to fail, cyanosis, lactic acidosis, and muscle rigidity. So it's kind of a hyper exaggeration of what is opposite of what is supposed to happen, like a paroxysmal response, but this can be quite deadly. So you need to immediately treat with cooling measures, stop that medication, make sure they're not getting any more of that, giving them more oxygen, and giving them dantrolene. Dantrolene is going to help reverse this kind of syndrome that's going on and help those muscles come back to contractions. But also we have the reversal for neostigmine, which is a direct reversal of this medication, which can also help with what the situation is going on. But dantrolene is an extra reversal for the cases of malignant hyperthermia. So make sure that we always have this on hand when we are sedating or paralyzing a client. And then the depolarizing, which is the succinylcholine, so sucks. So here we have that hyperkalemia. So the non-depolarizing does not have hyperkalemia, so make sure that you pay attention to that. This again mimics acetylcholine, causing muscle paralysis, but these ones do cross the blood-brain barrier. They still do allow for consciousness and pain. So again, same thing, make sure you're using an anxiolytic or sedative. You also have your malignant hyperthermia situation that could occur. Make sure you have that dantrolene again. And also muscle pain. With succinylcholine, for some reason, once they wake up, they may be like really sore, which could be positioning based on their surgery, but it also could just be from this medication if they got sex. And then hyperkalemia. So in clients that are already in a hyperkalemic state, such as trauma, burns, and potassium-sparing diuretics, we might not want to choose succinylcholine. We might want to use ones that are the non-depolarizing from the previous slide. In this case, for succinylcholine depolarizing, we do not want to ever give neostigmine because this is going to increase these effects of this medication, whereas it's the opposite for the non-depolarizing. So make sure you understand to not use neostigmine in this situation for succinylcholine. Make sure that we're carefully monitoring that respiratory function and having life support equipment available, of course, whenever we are going to do this, because again, we are paralyzing them, but they are fully conscious and aware of every pain sensation that is going on, unless you give them another additional medication. Next, we have muscle relaxants and antispasmodics. So diazepam is actually in this category as well, but it's also, of course, like we talked about before, benzodiazepine. And then additionally, we have dantrolene, which was our medication as a reversal for malignant hyperthermia situations. And then we have cyclobenzaprine and baclofen, so like muscle relaxers, Flexeril. These are going to mimic the GABA response in the spinal cord and the brain to produce sedative effects, and therefore depresses the spasticity of the muscles. So it kind of lowers that threshold of muscle spasms. But as a result, because of how it's working, we can have some CNS depression symptoms. So make sure that we're starting at the lowest dose possible and avoiding hazardous activities and concurrent other CNS depressants to decrease this effect. In that sense, that clients that may be taking this, especially if they are new to this medication, they may need assistance with their ADLs. If they may be perfectly able to do it besides the muscle spasms or pain before this medication, but once you've given them, their problem has been relieved, but now they may need assistance walking, brushing their teeth, things like that, because of how kind of drowsy their whole body feels. But we do need to monitor liver function while we're on this medication and watching for that hepatotoxicity. Muscarinic agonists, such as acetylcholine, These are going to cause relaxation of the trigone and sphincter muscles, and therefore contraction of the detrusor muscle to increase bladder pressure and excretion of urine. So these are going to make them more likely to pee. So when we're doing this for some reason that maybe they have bladder or urinary retention. And so this medication can help their bladder stop being so tight and let it release. So usually in these cases, we're already monitoring and taking output. Just be mindful of that. Some side effects more of this than anything else. You might get some complications for the bronchoconstriction if it interferes with your airway. Some bradycardia and hypotension, but there's usually pretty mild. And then self-limiting things like nausea, vomiting, abdominal cramps, and diarrhea, especially in the beginning. If they continue with the therapy, if they choose to continue, this may resolve. But if it's too much for their lifestyle and they cannot just keep going back to the restroom the first few weeks, then changing their medication for them might be necessary. And then sweating, tearing, and urinary urgency. So this is producing so it's like the opposite of anticholinergics, right? Instead of drying everything up, it's making everything wet and want to weep. And then we have muscarinic antagonists, such as oxybutynin. These are going to also act on the bladder, but in this sense, it's going to prevent contractions in the bladder and the urge to void. So maybe someone who has urinary leakage or bladder spasms, and so they want to help them stop accidentally peeing on themselves or having urgency issues. They might be on this medication. So it's actually going to do the opposite. So it's going to keep their bladder contracted. Antihistamines and tricyclic antidepressants can increase this blockage. So avoiding concurrent therapy might be advised just to prevent them from being too dried up. So they have the anticholinergic effects. So everything starts to dry up. You may have urinary retention, but that's kind of the reason that we're taking the medication, to cause these kind of symptoms. But if they can easily be dehydrated, so watching out for anticholinergic effects, and of course like self-limiting things about sucking on the sugar-free hard candies, sugar-free gum, drinking lots of water, ice chips, and things like that. They can also have some central nervous system or cardiovascular effects. It's pretty rare, but it can happen, so don't rule it out as something that may be happening, but it's not very common. And the next section from chapter 16 for sedative hypnotic medications. So first we have the benzodiazepines. So this is diazepam, razepam, midazolam, alprazolam, and clonazepam. So these are the AMs, the PAMs, the LAMs. These are going to enhance the action of GABA in the central nervous system, and again, treating anxiety, seizures, insomnia, and panic disorder, and are also used for anesthesia. So CNS depression is going to occur. Sometimes this is why we're giving it. We want to calm them down, right, for anesthesia, but making sure that we're avoiding any other CNS depressants and alcohol if they do have like a prescription for as needed for anxiety. Don't bombard this effect. We also have a paradoxical response again. So we're trying to give it for calming them down to stop their anxiety and hyperactivity, make them drowsy. But then, paradoxically, it causes the opposite reaction in these clients. I haven't really been able to figure out the reason why it does, or like statistically, if it affects more than this person It's just kind of random. I've seen it twice. but paradoxical because, again, it's the opposite reaction than what was intended. So monitoring for those. Nausea, vomiting, and anorexia, of course, can happen. Monitoring respiratory function for respiratory depression. So making sure, they're still breathing effectively, they're taking those deep breaths, incentive spirometer, oxygen saturation is good, they're taking good cough hygiene, things like that, to make sure that they're not going to develop any problems from there, or lead to respiratory arrest if we don't address it soon enough. These medications can also lead to physical dependence, so monitoring for addiction symptoms or signs. Benzo addiction in the United States is quite common, and so some statistics here on this picture. So about 80% are involved with diazepines. Then we have acute toxicity. Just like with the other medication mentioned before, the toxicity is going to change symptoms based on the route. So if they're getting PO, lorazepam, they may have some drowsiness, lethargy, and confusion. And in this case, we're going to need to do a gastric lavage. And after this is completed, if they're still having symptoms, then we resort to the activated charcoal or saline cathartics. This is not our first choice. Gastric lavage is the first choice to get that out of the stomach. IV toxicity is going to look like respiratory depression and cardiac arrest, and make sure that we have flumazenil at the bedside or available as our reversal to counteract the sedation and reverse the adverse effects from these medications. Use cautiously of those with a history of abuse, of course, liver dysfunction or kidney failure. And older adults may require an adjusted dosage just because of their already liver and kidney function may be a little altered, and so they can have an exaggerated response of sedation from these medications. So make sure we're using our smallest dose possible and incrementally increasing, like in the sedation world. We would always start very slow with older adults because it may take longer for it to become effective and have the effects on them, but then when you give another round or another dose, it can be on top of the previous dose that is still being processed. They have a slower metabolism, I guess is what I'm saying, of these medications. So being mindful of that so that we're not overdosing them. Non-benzodiazepines such as zolpidem. So a lot of the medications, I think, that I've noticed, if their genetic name has like a Z in it, they're probably going to cause sedation. Zolpidem, we're taking this one for sleepiness. This is going to act in the CNS to prolong sleep duration and decrease wakenings for treatment of acute insomnia. But these don't function as treatment for anxiety, muscle relaxant, or anti-epilepsy, so treatment of seizures, and therefore has a low risk of tolerance, abuse, or dependence because there's no euphoria effect from it as well. But daytime sleepiness, lightheadedness, and headache can occur, so educating them to make sure that they administer it at bedtime, which is going to be the case for most medications that cause sedation, taking it at bedtime so they have less effects that interfere with their life. But this one is different because we want to take it on an empty stomach. Make sure that when they take it, that they have at least 8 hours of sleep from the time that they've taken it to the time that they're going to have to wake up, because again, it's decreasing awakenings for our treatment of insomnia. So don't take this and plan to wake up in 2 hours. You're probably going to oversleep your alarm. And then avoiding any other CNS depressants and alcohol also. Melatonin agonists such as
melatonin activates melatonin receptors for chronic insomnia when falling asleep is difficult, but doesn't help maintain sleep. It just helps them start. So this may be used in conjunction with the previous one because that keeps them asleep. But if they're still having trouble falling asleep, they may add melatonin or melatonin as a prescription version. Of course, sleepiness, dizziness, and fatigue can occur, and hormonal effects, oddly enough. So they can have a decreased libido, amenorrhea, and even infertility with long-term effects of this medication. And make sure that we're monitoring liver function, and if they already have a history of liver disease, that depending on the severity of the liver disease, we might want to be cautious or decide that it's just not worth it for them. So it'd be contraindicated for like severe liver failure. And then we come to IV anesthetics for non-opioids. So these are going to include phenobarbital, propofol, ketamine, and again, benzos. Benzos are like the catch-all drug. So IV anesthetics that are non-opioids are going to cause loss of consciousness and elimination of response to painful stimuli for anesthesia, induction, moderate sedation, and intubation and mechanical ventilation. So these are the type of medications that we might give in a combination to those paralytics that we talked about before to inhibit the pain response and consciousness. But here again, we have respiratory concerns, respiratory depression. Then we also have cardiovascular depression, so watching the cardiovascular status. And hypotension is usually what will occur in this situation, and not hyper. So the blood pressure will start to drop, and so monitoring for those things. Propofol, which is this lovely white liquid, looks like milk, can also lead to bacterial infections. And I am not sure the reason for that, but it can happen on occasion after surgery if they are in this percentage of people. Again, I don't know why or like any statistics about this. It's just something odd. I've never come across it, but I have been educated about it when I was covering for people in PACU and things, but monitoring for a sudden bacterial infection or a sudden increase in white count, which after surgery, we're expected to have a little bit of a white count elevated because of the inflammatory and immune response after they've been cut open. But then once it's repeated again, it's continuing to still climb and not settling out, then we need to look for infection. And this can then be not because of the surgery, but because of the medication that they got. So their surgery site could become easily infected after the surgery, and it's not because they didn't use sterile technique, they didn't clean or lavage everything. It's because they have this response to propofol, and that's just the easiest place for a bacterial infection to start growing. And then we have psychological reactions. So this is usually more so with ketamine than any of the other ones. So they can get hallucinations. Quite freaky, kind of like that paradoxical response. We're trying to sedate them and then, shut down their brain, but then their brain is firing off hallucinations, and they get confused when they start to wake up. So, especially in young children or older adults, I've seen it in young children in this case. So especially when they're starting to come out of that sedative effects, when they're starting to wake up after anesthesia, make sure that we're having a quiet, low stimulus environment, and that we're trying to, decrease the stimuli on the brain function while it's trying to recover and wake up from ketamine. We can also give diazepam or midazolam, which is Versed, prior to ketamine in order to reduce this effect. But
doctor preferences, they may not always want to use Versed, the midazolam, especially in pediatrics. And so, because it's so rare to have this reaction, but when it does happen, and you learn that we could have just used Versed before we started the procedure, but too late now. Learn about it later. And then any client that already has a history of mental illness, try and make sure that we avoid using this medications, ketamine, with those clients, because they already have mental illness and misfires and things going on in their brain function. So we don't want to increase that effect by giving them ketamine if we don't have to. And then IV anesthetics that are opioids, such as fentanyl and morphine. So this is going to cause loss of consciousness and elimination of painful stimuli. For anesthesia induction, moderate sedation and intubation or mechanical ventilation. This is usually also used in combination with the previous slide for the non-opioids and or the paralytics to promote that pain response. Prevent that pain response. This may not necessarily cause loss of consciousness if it was used on its own, but it does eliminate pain on its own. Usually, though, we use it in combination with those other types of medications and therefore are more likely to cause loss of consciousness. And of course, we have opioid effects because these are considered opioids. So make sure you refresh your memory on what opioids look like in clients. And then respiratory, cardiovascular depression, and hypotension, again with these medications, just like with the non-opioids. So the only difference between these two are that we have the additional opioid effects. And the ketamine issue is not an opioid, so it doesn't apply here. So these came from chapters 7, 15, and 16 from your ATI textbook. Thank you.